Everybody hear me? Yeah. Well, I really appreciate you all coming out here tonight, Thursday night, and sitting here and listening to hopefully some important discussions regarding education of kids with mood and differences. Just want a show of hands. I think it's always important I know who my audience is. It's supposed to be parents. Is anybody in here have a child or a relative with a mood or bipolar disorder? Yeah. Okay. Thank you. Yeah. And anybody in the schools that work in the schools? Yeah, I know this guy does. Great. And I know there's some grad students here. Appreciate you coming out as well. Wonderful. Well, I think we're going to take about an hour tonight to talk, and I'm going to try to make this interesting. And at any time you have questions about the slides, just raise your hand and I'll answer questions immediately rather than waiting to the end. And I'll keep us going along, but just so you don't have to remember at the end. And then after the discussion, I'll be around for a few minutes to answer your questions. But subsequent to this lecture, if there's any questions, I made sure and put my phone number. It's my cell phone, and you can always call, and I'll get back to any questions you have about the system. Yeah. So just a little bit about where I'm coming from in my professional career. I'm coming into this research building here, and I do about this much research on a daily basis. So I consider myself a practitioner. I'm out there on the front line working with children every day. And where they're doing all the science in here, I take that and read through it and try to interpret it and try to make it practical so that kids receive what we call in special ed as an appropriate education. I currently work for the past 7 years at the Sweetwater School District. It's a high school district serving about 40,000 kids in the South Bay, middle school, high school. And so, as kids get to be teenagers, you get the secondary effects of a lot of problems that early on may have been more minor, more academic, more treatable. We get them in the high school level when things can get pretty unstable for a lot of reasons. I work with kids currently in this district who are in non-public schools and who we can't educate, so we look around the county for kids and we place them in what we call NPS. And at those schools, they still have to follow the special ed laws. So my job is to go out and make sure they follow the IEP, they follow the special ed laws, even in the private school setting. Okay? For the last probably 8-9 years, I've been with Brandon University, formerly Chapman University. I'm a trainer for graduate students in school psychology and school counseling. So I've been mentoring for almost a decade students into graduate level courses and getting them out into the field working with kids. So that helps me feel good knowing that I get to train people that are eventually going to work with kids. And then for the past 6 years, adjunct at San Diego State, teaching neuropsychology in their graduate program for the school psychology and school counseling program. So I work a little bit in different levels, and I like to keep my feet in. I have a practice that I do work in as well. So I see kids from every district in the county, whether the district refers them to me or the parents refer them or an attorney or different folks need questions answered. My goal is to answer questions when it comes to children. So I was, doing a lot of reading, like anybody would, to prepare for this. I want to know what's current. I want to be on top of things with any kid I work with. And this just struck me, a quote from a parent that I'd read about. And I think that I do not know what it's like to parent an individual with a mood condition at the moment. I have 3 little ones, and you never know where life's going to take you. But this was an important quote to me because I look at this in the schools and I say, these are the hard kids to teach because they're not always lovable. They're not always accepting of what we have to give them. And that's what makes it complex, okay? I think that I worked a lot with kids with autism. That's another area I'm real interested in. And one of my parents once told me, when I go to the grocery store, And my kid with autism is having a sensory difference or issue and having a meltdown that we get a lot of looks from people. And some days, she says, some days I wish my kid had, a cast on or something, something where people would say, oh, he's got a disability, that's the issue. But conditions such as these, where they're internalizing conditions like developmental differences and neurological, psychological difference, there's nothing on your forehead that says it's, this is just my disability, it's not who I am. And I think that's a really difficult thing, especially in public schools, kids falling out of the chair, cussing at a teacher. We send that kid to the principal's office and not knowing the pathology behind it, not really understanding the why. So I'm going to go through tonight and talk a little bit about neuropsychological differences. And I'm going to talk a little bit about learning aspects and assessment in the schools, importance for students with mood differences like bipolar. I'm going to talk about public and private school services for these learners. And then I'm going to talk a little bit about supports there's a litany of books on pediatric bipolar. I think there's a lot of good information out there. If my child had a mood disorder right now, I'd be much better off than I was maybe 10 years ago, when there was about one book out there, Papalos's book, that that was out there talking about real strategies for kids. I went on a shopping spree in November when I was going to do this, and so I have a stack of books, and I was very surprised how much is out there. So, and if anybody would like those resources, I'd like to email me or phone me for children, particularly. And then these Wordles are kind of, an interesting design. You go to Wordle.com and type in some letters that describe characteristics of children with mood differences. And look what's going on here. There's a lot of differences. I think everybody would agree that this is a complex thing, okay? I work with kids with dyslexia, and reading is their difference. Reading affects their neurological difference affects reading. When you talk about a pervasive difference like a mood condition that has so many facets that intertwine into their day, it's a real complex thing. I don't believe I'm going to be able to capture it all in 1 hour, just so you know. But I'm going to try to highlight some things and leave you with these slides for further knowledge. So I went on Google and I thought, let's just find out a little bit of what, anybody use Google Scholar? You wanted to have all these research items up electronically, but just take a look at this here. So I typed in childhood bipolar, and I limited the dates here from 90 to 99, and we have almost 10,000 hits here, okay? In 10 years, about 1,000 bits of research, scholarly research every year, 1,000 every year. Look at 2000 to 2010, and now we're up here close to 40,000. And then this last year alone, we're at 15,000 bits of research in 1 year. So everything that I had read up until this point, and all of anybody used iTunes University to look at the lectures, they have a plethora of information there, particularly with psychiatric conditions and mood, and even pediatric. So since 1996, I was listening and reading, and in 96 they were saying, we're starting to see a rise here, we're starting to see a rise here, and sure enough, this has been talked about a lot. I'm not going to spend a lot of time discussing the why in the increase. I will have a little bit of information, but it's pretty clear that the diagnostic manual that has been updated over time is very influential on the rise in pediatric bipolar disorder, very influential. Where things like autism, it's been on the rise a lot, but the diagnostic criteria have been pretty stable over time. So we all know in here it's brain-based. So early on, I think, even as 10 years ago, we thought of this as the psychiatric thing, this psychological thing. But as science progresses, and the kind of things maybe they do here or across the street, we kind of can start seeing, hey, there's some similarities in brain functioning in certain groups of mood conditions. And so it's very much recognized now that bipolar disorder stems from neurological differences. Okay? Causes severe fluctuations in mood, energy, thinking, and behavior. And you know, pop culture, you have somebody wakes up in a bad mood, and it's so not funny, but you know, you hear it all the time. Well, I think I'm bipolar, and I say, no. See this word severe here? You're just having a bad day. 364 days of the year, you're fine. Don't minimize this condition. This is severe, okay? Energy, thinking, and behavior. And we know it's some people, older folks may know this more as manic depression causes moods to shift between mania and depression. And the children in the research present differently with their symptoms. They can experience a mixed sort of combination of these two different states that can be severe and sudden, and also this rapid cycling. So where some of us may experience once every 3 years this cycling, these things happen more often in schools. It makes it really complex, in my opinion, for educators to predict, to prepare for. The symptoms of mania also, like I said, can occur simultaneously. And then we have a lot of anxiety and low frustration tolerance that can occur. And then if we look a little bit about history, under 20 years of age drastically increased in less than 10 years. Comprehensive study. So here's from the journal, or the archives of the journal Psychiatry, and this was about, I believe, about 2004. Went back and looked at some numbers here. This is a really common study. If you get on and read about this study, you see that we've got, this is what sort of began, I think, people thinking about why is this such a 40, I mean, this was such a huge number. You have, so 25, from 94 to 95, 25 per 100,000 visits that go into the hospital come out with a bipolar diagnosis, okay? And then we have 2002, 2003, that number had risen now to 1,003 per 100,000. And say, this is 03, you look out there and listen to people talk, it's even higher than that today. Okay? So, in the educational field, I think in the 80s, there was dyslexia. In the 90s, it was sort of this ADHD was really gotten a lot of attention. And then as the later 90s came about, we saw autism, and through the first part of this millennium here, we see
was it mood disorders, or also they use that for bipolar, that the person's mood changed, and
Yep.
before they knew they were bipolar.
That's right. There are a lot of factors for that increase, I believe. But there's no doubt, as a practitioner in the schools, in the 13 years I've been in public schools in San Diego, seen a huge amount of increase in people talking about it, and people learning about it and dealing with it and trying to understand it more.
When my children were little and I raised 5, they used to call this multiple personality disorder. They didn't have the word bipolar.
Wow, where was this at? Or just
No, here in
here?
San Diego.
Yeah.
In my 20s.
Yeah, what an
In their 20s,
evolution.
when they were little, they had nothing. They just said she's not behaving right. And
Yeah.
not a successful
Yeah,
child.
I had my shoes had to be 2 inches apart. Everything.
Yeah,
Is it?
very specific
Mhm.
in order. So, just another visual, that's, this image is out there quite a bit, but just looking at the difference here, most of us come to school every day with the same issues, our strengths and limitations. If I can't read, or if I'm having reading disabilities, I come to school pretty much the same every day, having those same issues. But look at this fluctuation here, when children come to school in such a different state, that's constantly changing and interacting with the environment. It's a very challenging condition to educate, let alone live with and parent and treat. So, just a little discussion, a note here. The DSM-5's coming out, more changes. I don't want to sit here and talk a lot about that. I'm not an expert in DSM, but we have to know that enough to know what's up the road for us in the schools and what kids are going to be coming to schools with. But if you look at that population of individuals, particularly children, who are underserved and who are often misdiagnosed. So there's a whole group of individuals out there that are pretty adamant that we're overdiagnosing bipolar. And what follows along with a diagnosis of a mood disorder like bipolar is what? The next step is medication usually. And so there's a lot of individuals out there who are very cautious. There are a lot of groups out there that are very cautious about this path of treatment. And so there's individuals out there that have studied differences to kids with these kinds of symptoms. Do they later on develop the actual bipolar type 1 later on? And there's a lot of studies out there that say not all of them do. Diagnosed here early on, not all of them go up and develop type 1. So why is that? Do they grow out of it? I don't think there's a cure yet. So is it possible it's something different altogether? So this disruptive mood dysregulation disorders coming out in April or March. And kids fail to get appropriate treatment, often get inaccurately labeled and diagnosed, a diagnosis that implies a lifetime of mood cycling and medication. So there's the camp out there that says, well, these doctors are too cautious of making this diagnosis, and maybe not getting the right treatment. And there's many practitioners out there that I've spoken to and said, we're real cautious before we give this diagnosis. We've got to track this for a long time. Yes? Mm-hmm.
Yeah, and wasn't it called, because I was diagnosed in 1981 when I was 21 years old with major depression and manic depression, and now it's called, of course, bipolar. And
Yeah.
I had to go to a lot of groups, and everybody, all the young people wanted to know, how I got in there, and said I had bipolar disorder, and so they tried to use that to get out of a lot of different things in their lives. But
Sure. Yeah, and how this evolves is incredible. At the end of the day, whatever it gets called, I want to know what the symptoms are, and I want to know enough about it so that I can put an educational program together and make sure this child's educated. I don't have controls over what they call it. That's another group of folks, but it is changing, just like everything else does in that book for the most part. It evolves, right? But look at some of the diagnoses that mimic, mask, and even co-occur, and look at how complex this is. And again, I'm coming from an educational perspective. You can get kids in, with conditions. You don't often see all of this other stuff here. So it's, and we know that you add a couple of these to somebody's position as they come into school, and now you're talking about the complexity level just rises significantly, and it's real, difficult. We often, anybody seen this image before? It's out there, and I show this to my graduate students, and what I want them to appreciate, what I want a school psychologist to appreciate is that look at how closely this disorder resembles some of this other stuff. And so often, and this is very clear in the research that, and anecdotally as a practitioner, early on these children have the title of ADHD, anxiety, and then we see the depression come along, and then it gets looked at again because we still haven't understood it enough, and now we have somebody that says, you know what, we see this pattern here now that doesn't just look like ADHD, or the depression's going up, and the mood fluctuates in such a pattern, but it sure is a different kid that comes to school one day versus the next, and I'm sure you in the audience are nodding. I can appreciate that, and that's my goal, my passion is to help people in the schools appreciate and what to do. We'll talk more about that. How many of you heard of special ed and IDEA, special ed laws? 75, I think it was President Ford then, on his way, getting in a plane on his way to China, had one of his advisors run out and say, wait, you got to sign this before you go to China, you got to sign this. And he was reluctant to sign this piece of legislation, but he did. There was a lot of parent groups, there's a huge amount of people out there that wanted this legislation signed. And he did, but he looked at his advisor and he said, I don't know how we're going to pay for this. And what he signed that day was what we now know as Special Ed Law PL 94-142, the Americans with Disabilities Act, or IDEA, and that's what protects kids with disabilities today. And surprise, is still not funded fully today. So Ford was sort of right in his gut feeling and his anxiety that how is this ever going to be paid for? So, and that's part of the crux of special ed. But there are laws in schools that protect kids and kids with mood disorders. And this isn't a law class, and this isn't a law seminar here, but that's an important aspect of the educational environment, is making sure that we have knowledge and we have programs that are put into place that are explicit in how to help a kid learn. Okay? But since then, much has evolved in the field of education and neuroscience. We've had this process of assessment advanced as well, and with neuroscience making a major contribution to that. In 2004, we see now that we have the word evidence-based treatments being put into place. My belief is that a diagnosis, an accurate diagnosis is important. An accurate educational diagnosis is important before we know what medicine. You know, most of us go to the doctor and we don't say, here, take this and we'll work on it. You know, if this works, it must be this. You know, we take time to find out the diagnosis, yes.
Yeah, and I was just going to say that if a person has been an alcoholic or has been a drinker and smoking pot, they cannot get a correct diagnosis when they're under the influence of something. They have to wait till the child's perfectly off everything, which is hard to know.
Hard, right? That's part of the characteristics, part of the issue, right? Mood and mania and hypomanic phases. But this assessment has most recently made promising advances, and I want to talk about that for a moment, this assessment piece and education for children with mood disabilities and disorders. What we have here is this idea of a school-based neuropsychological assessment, and neuropsychological assessments came out of rehabilitation, and particularly with adults, like most tests, you know, especially like IQ tests and so forth, with adults. And so it was a really long time before these approaches to looking at children made their way into the public school system. These tests that we were giving to adults weren't normed on children, right? And it wasn't like a medication where we can just titrate it or change the dosage for the, you know, the weight and body mass and so forth. You can't just give those same tests. So we've known all along that there's ways of looking at the brain and making those connections with behavior. But most recently, those things have come into the school, so now we can do evaluations and look at kids in that way. Old tests were normed on adults. This is an educational base versus these classic neuropsychological assessments a lot of time are very clinical and very medical based, looking at deficits instead of strengths and deficits. Focuses on, these kinds of evaluations focus on the relationship between brain and behavior. And so making those connections, comprehensive, thorough, trained clinician who connects outcomes with evidence-based treatments. So when you're in the schools, a lot of times there's a lot of great ways of assessing kids, but then how do we get it in the classroom? And that's been a problem for many educators and many parents, is that the people that are making these assessments, it's not always able to get that into the classroom for the teacher to understand it and to do her or his job of teaching, okay? So what are these kinds of assessments? They're very thorough, they're extensive. They involve a lot of different areas of processing here, and we're looking at a lot of different things. It's a very comprehensive approach to looking at kids. It takes 3 times as long as a typical psychoeducational assessment. Fluency, and looking at speed of output. I'm going to make sure to keep on time here, bless you. But if you look at bipolar disorder, I'm going to talk a little bit about these areas. There's a litany of research out there about the neurological deficits, and some of them are conflicting because this is a hard group, I believe, bless you, the hard group to look at. You look at kids with mood disabilities, I believe it's a hard group to look at because there's very different issues going on at any given time. If you're hypomanic, you have a different amount of symptoms than if you're depressed. So I can't make a global generalization that you have a processing speed deficit when you're depressed and you're low, and generalize that to when you're in a manic phase. Yeah, it's almost like two different types of assessing there, two different plans. There's a lot of history and putting all this together. Has anybody ever in here had a child that go through the special education system and get assessed in schools? Yeah. Yeah.
I'd actually like to bring something up. Actually, if I had my son that was assessed while he was cycling, and the psychologist didn't realize that, and when I brought it to her attention, it denied it. And it was clear that he was cycling, and even the teacher agreed with me, and had I known then what an IEE was, I would have declined the assessment.
Yeah.
Because it was so off base. I didn't know about what it was back then. But she was so new, she was like an intern the semester before, because she worked where I work, with somebody, that she didn't even realize that whole assessment that she did was invalid because he was cycling during the whole assessment.
Yeah, that's a good example of the complexities of an evaluation like this with children with mood differences, is that they fluctuate, and you have to be able to recognize that and be cautious when you go through this process. Yeah.
It really did. It put out that I mean, unless you really went back and looked at the charts, I guess you wouldn't know that if you didn't know the student.
Yeah, and especially young kids. When I'm evaluating a really young kid, you know, we have to be very open-minded and very open to the fact that what we're seeing as being deficit right now may change a little bit depending on those biochemical differences. But when we look at attention and executive function, so in the research, in literature, there's a litany of information out there about the underperformance of this frontal area of the brain called the frontal lobe. Okay, and in a nutshell, the frontal lobe of our brain is in control of everything. It's our executor, and you see a lot of differences in kids with mood disabilities. This area should be measured and should be evaluated to some degree, whether it be qualitatively or quantitatively with standardized measures. You have to appreciate it and understand its contributions to learning and its limitations to learning secondary to the mood cycling. We see it's responsible for problem solving and sequencing. These are some of the deficits that studies have found in kids with mood disorders. The shifting of attention. How many of you know that it's so hard for kids with mood disorders to start something first, and then once we're started, now we have to change, and we're not ready to change right yet. We don't want to change.
Yeah, that's what I
Yeah. Yeah, that's what some of the, in my experience with kids, some of the hardest things is that inability to change that, what they call cognitive set. So my brain, my mind, my attention is set on this, and now you want me to change it and shift my attention. I'm not ready to do that, and I'm very anxious if you force me to do that. I'm not sure what I'm going into next.
Right, when there's like 3 different things that you have to take care of. For me, it gets to be where I become, I forget what time it is. I have to go to a group, and all of a sudden I look up because I started one thing, and then I have to do all these other paperwork things, and then I have to go to group, then I have to take care of myself and make sure bills are paid, this and that, doctors, caseworkers.
Yeah.
So it all of a sudden, it makes me feel sometimes like I just want to explode, but I don't.
Yeah, good.
Because I'm on medication.
Yeah, well, and you've learned a lot in your life, I'm sure.
Yes.
Whether it be good or bad, you've learned a lot. But when you look at, and so people say, well, okay, so you measure that, it's a difficult thing for kids with this problem, but what now? And the idea that if I can take this idea that you're saying in this construct of shifting attention and bring it into the classroom and help educators understand it and conceptualize it, because if we can't call it something, sometimes it's hard to understand what it is. It's the whole idea, the double-edged sword of labeling. I hate labeling, and I'm in a business to label kids. I don't want to be labeled. Everybody always comes up to me, what do you do? Can't you ask me like what I like? But what do you do? Well, who cares what I do? What about this? And it's this the world we live in. But sometimes by defining something in a meaningful way to somebody else, that person now has that knowledge to help teach and help support the kid. Impulsiveness and attentiveness, purposeful behavior is an aspect of this frontal area, and impulse control. And then the considerations of medication of this area. We know, I'm not going to talk about pharmacological aspects of bipolar, but that's a whole nother lecture connected to this, and now you double the slides and saying, oh yeah, and what about this medication when a person's cycling, and what's an antiepileptic drug going to do to a cognitive process?
Is it possible when I got in a car accident, I was on my bicycle and the truck came from behind and witnesses saw it and gunned it, and I flew over my bike and landed prefrontal lobe over here, and then after that I tried, a month later to go back to work, and I wasn't very nice at all
Yeah.
to some of the people, and it was just, I'm just wondering if that would
Oh
cause,
yeah.
I mean, cause
So-
seizures, which I have now, and
Yep.
brain
Well,
injury.
well, if we look at this frontal area here down below, it's real closely connected to our limbic system and our emotional systems in the brain. So there's a high amount of influence that area of the brain affected, the insult that you occurred affected your emotional status and your emotional regulation, things like that, absolutely. Yeah. And so then we have memory functions. And I think when I ask most people about, what's important in school, and most, if you ask 10 people on the street, what's important, what brain function's important in school, and most people would say memory. And that's very true. But there's many facets of memory. There's a lot of different kinds of memory that we want to look at. I have to have a lot of working memory right now, and I'm using that real intensively to connect my ideas so that I stay on topic. And if I don't use my working memory, I start rambling about things just sort of free-flowing, and I'm not staying on topic. So we have this executive system working with my memory, working memory system. We have verbal memory, visual memory. We have the limbic system and its contributions to emotional memories. And this is a lot of research about the limbic system and its effect on memories with kids with mood disorders. This idea that our limbic system is sort of overworking at times in this fight or flight mode. And because we have some memory of this that may be negative, or I may perceive this as being a bad situation. And now my fight or flight systems are working a little bit too hard. In other words, my heart's starting to race and I'm dysregulating, so to speak. And I need to have my frontal part of my brain come back and tell my limbic system to calm down. It's okay. This is my teacher, or this is a sub. It's going to be okay. These things all need to work together. But memory is very important, and it's difficult. This working memory is difficult with kids with mood disorders. It's this ability to hold on to things for a bit of a time, and to hold on to that and do something with it. If I asked you to copy everything down here, at the moment that you take your eyes off this slide and start writing, that's all that's in your mind is working memory that gets on that paper. It's a short, a second's worth of information. But if you don't have working memory, you're not going to be able to you're going to be looking letter for letter here. S, H, O, or maybe short, because you see the word short, and you can hold on to that. But some of you can take this whole thing right now and be able to copy it down on your paper. That's how good your working memory is, your visual working memory. So there's many different aspects of memory that can affect kids at different parts of their learning process. It's important to understand that. If you go to you're in a school and somebody says, well, this kid has poor memory, and then you say, well, what kind? Well, we don't know, just poor memory. It's not enough, right? We look at sensory motor, where output is a big part of what is demanded in school. And these fine motor skills are important. We want to look at bilateral, both how the right and left work together, and the speed of output. This is a difficulty for kids with mood disorders. and then you add some of the medication that makes it more complex. But that ability to focus and get output is really impaired sometimes. That can affect motor speed. So we want to try to understand that. We want to try to look at motor and watch and see, is this coming out okay? Do we need to make accommodations for this kind of thing? Medication sometimes can cause tremoring, and a lot of tremoring, and that can affect motor output. We want to recognize that. Not every kid experiences that with medication, but some kids do. And writing becomes very difficult. So writing is the last thing that comes in language, right? We hear it, we speak it, we read it, and then we write it. It takes a whole bunch of executive skills and motor skills to do this writing, which is a huge problem. I've had 2 kids in my experience in the South Bay with mood disorders, not even take the exit exam writing part, but they still passed it. And they looked at me and said, see, I'm smart enough to pass this, but I didn't even write the essay. And I said, well, okay, fine, you passed the test, but they just didn't even want to, both of them, they didn't even want to look at the writing. It was so, such a daunting thing for them. And even when we asked them if they wanted somebody to read it out for them, but this writing can be a huge amount. It takes a lot of brain power to write. And especially, and not just free write, I'm talking about, I'm going to tell you something and you've got to write me an essay about it. It takes a lot of brain working together in sync. And not all those parts work together very well together to get the problem. And then we have sensory. And this is a whole nother area that could be talked about a lot, because there's a lot of research out there that kids experience a lot of sensory differences, sound, touch, sensory kinds of issues that we need to also appreciate in the school, especially when we're looking at triggers for behavior, okay? What's triggering this right now? And then language. Expressive language is speech patterns and access to those language files. We want kids to communicate sometimes. Well, just tell us when you're having a bad moment. Well, I can't access my language right now because I'm cycling in such a way that I can't get there. I basically can't access my language file, and that can be impaired. It's easy to do it one-on-one with a clinician where everything's fine. Sometimes you put all this out in the moment, that it's very difficult. Receptive language, this is what we hear coming in, that we're receiving. Auditory processing of this language. How are we hearing it? Is there distractions in the air, in the classroom that are affecting the way I receive what you're saying? Pragmatic language of communication, so it's how we say things. Kids with mood disorders, very, very commonly known that we misinterpret social cues. So many times this has happened where we say, well, that's what he's perceiving, but I'm not really doing that. Yeah, but that's what he's perceiving at the moment, so we need to teach him strategies for that. I didn't look bad at him. I wasn't say it mean, but he will interpret that, and it's that amygdala again. It's coming in this fight or flight, and if you have a neutral face, I'm going to read negative instead of positive more often than not. We walked around, all of us in this room, and every time we saw somebody's face as neutral, we thought that as negative. That would get to us over time. It would affect how we interact with people. It may make me more frightened. It may make me more aggressive or defensive over time. Both anxiety and attention can affect language. So there's not a whole bunch of research out there that says if you have bipolar disorder, you're going to have a language disorder too. That relationship, to my knowledge, doesn't exist. However, we know things that mediate language. If I'm too nervous right now in front of you, I'm going to stutter, I may lose what I'm going to say, and I'm not going to be able to say it. So we have to look at these things that are comorbid and are indicative of kids with mood disorders that may affect language and language output. And that's important. It's going to exacerbate difficulties in regulation. Okay? Because in schools, we're always trying to say, well, just tell us. Just communicate. If you're having a bad day, just let us know. And that's not as easy as it sounds for normal adults.
Can I ask a question?
Yes.
Have you ever seen or heard of when there's a comorbid condition of hyperhidrosis, which is right handwriting with children with bipolar? Or their hands, there's some cranial nerve that overexpresses, I guess it's neurological too, and their hands like profusely sweat when they're anxious. It's got to do with the anxiety. It overproduces, their hands profusely sweat, and it's triggered with the anxiety, and apparently it's kind of like, I guess, with bipolar. They said it kind of goes hand in hand.
Sure.
Have you ever
Yeah,
heard of it?
I'm not familiar
I've
with
seen it.
So
hyperhidrosis.
usually your mind, bipolar, is going faster than you can actually write.
So and that causes anxiety when your mind's going faster than you can write, which then causes the endocrine system or the, some system into,
Right.
I don't
yeah.
know. I was told it was neurological. There's a cranial nerve that overproduces, and I don't really think that there's truth in the answer. I just wondered if you had heard.
Yeah. No, so I haven't read about that, and I haven't noticed it, but I do see this come out a lot in this, and again, so written output, if your mind's going real fast and your motor systems aren't able to keep up with it, you see that can cause a whole bunch of frustration.
Talking like hands soaking wet. Like
Oh,
that.
wow.
It's totally, it's something stimulated within, it's something stimulated within the cranial nerve system.
Yeah, that's going to cause frustration for sure.
Yeah, well,
Pencil-
yeah, because you
pencil
can't get it
can't.
treated till you're like 21 by a medical board. They won't touch you till you're 21. I was curious.
And then fluency and processing speed. So whether it's processing what somebody's saying or processing of output, so motor speed and talking and learning. Anxiety levels mediate this, mood levels, side effects from medication, and attention levels. So attention deficits can affect the ability to get things out, because it takes a lot of concentration to know what we're going to write, know what we're going to do, and it's very complex. Anxiety levels can cause difficulties with processing speed. So in schools, we know that time is of an essence. We've got to take the state test every year. We've got to measure benchmarks. We've got to move through the curriculum. So this pace is real fast right now. I think one of the biggest difficulties I've observed in kids with mood differences, especially in the teenage group, the adolescent group, is this processing of speed, this fluency. You need to do it faster. Because these kids, by and large, have average to above average cognitive skills. They're very bright. And we know that the brighter you are, the more able you are to see and reason things, more likely are you going to look at yourself and see your deficits and go, darn it, I know I should be able to do this. Everybody else is doing it, but why can't I? And then you start to add on a frustration. So understanding how output, speed, comprehension, processing speed, taking this in, affects kids in schools is imperative. And then we have the social emotional aspects, and I think there's a lot of good psychologists out there that take a good look at social emotional and evaluate it certainly on a surface level, but then making the connection to the dynamics of bipolar disorder is daunting. In schools, we have 60 days to get an assessment done and then hold a meeting and discuss our findings. And we don't get to we're not sure what this is right now, rule this out, maybe it could be this. We have to come out with a definitive answer. This kid either meets special education requirements or doesn't. And it's a fast process. And if you're a parent, waiting 60 days sounds forever. If you're a psychologist in a school, 60 days sounds like not enough time. So it's an interesting conundrum. But when we look at social emotional, we see this a lot. Somatic complaints. We have a lot of different issues, either psychosomatic or real somatic complaints that kids, and so they're avoiding things. We have to look at that in the schools. We have to see that, oh, the best place for me to find a lot of kids with mood disorders is to go talk to the nurse first. When I start at a new school, my first job is to meet that nurse and tell her some things I want to know and ask her who the kids are that are always coming out, and then you find out there's nothing wrong with them, so you send them back. The nurse really knows a lot of this. That's that window there. And then processing, how we solve problems when we're in that state of rage or hypomania or anger. We have to understand the limbic system's contributions to this, and I shed a little bit of light on that earlier, that, you know, what are the triggers to some of this behavior? And is it in fact, because many kids with bipolar, you talk about bipolar in the schools and people say, oh, well, that's that aggressive kid or that mean kid that just goes punching, you know. But nobody sees what happens before that or what led up to that most times. And what we find here is that it's a defensive mechanism. We're just in a defense mode. And we don't know how to operate right now. And we're also out of control of our emotions and our behaviors. And that's all here from this limbic area that is over-aroused. And then I just talked about facial affective cue recognition deficits. So I'm looking at your face, and then all of a sudden, my limbic system goes on high alert because I think you're mad at me, and I didn't do anything wrong. And you find out, well, really, the teacher wasn't mad at you, and the teacher is even telling you right now. And it's like, really? But no, but I was certain, and I hold on to that, but I was certain. And we have to deal with that in the schools, and we have to help kids overcome and look around and say, you know, why would, you know, when these kinds of things happen, what do we look around for to see, to rule out that this, in fact, teacher is not mad at me? And then we have an oversensitivity to negative words and criticism. Huge oversensitivity for a lot of reasons to criticism and to negative words. It's been something I've observed myself with kids, that we've had to go in and train teachers and talk to teachers about how we say things. And it's hard. So I have to know what words to say to this kid. Well, or you can deal with that. Let's start on the front end and see if we can reduce some of that. We also have this cognitive rigidity. You know, and we talked about that a little bit earlier, where it's like my way or the highway, or I can't think of a different way of doing things. We get stuck on things, and it's hard to step out and say, oh wait, maybe there's another way to solve this problem. It's this rigidity of thinking that happens. And we said dysregulation. We have some anxiety-based things here, like obsessive-compulsive kinds of behaviors. Many times kids will get in this place where they're thinking about this thing, and you can't get them to stop thinking about it. And this obsessiveness sometimes leads into compulsive behaviors. Well, I've got to go do this then. I've got to go move that. You see that kind of come along sometimes. And then the oppositional defiance, so ODD, this oppositional defiance. And it's not because we're a mean kid. It's my job as a psychologist to find out why this kid is oppositional. There's a reason for every behavior. We have to believe that. And we have to understand what those reasons are. And then to a lesser degree, there are comorbidity in the literature of something called conduct disorder. And these kids are rule breakers. So this is when we break the rights of others. You know, and that crosses the threshold for a lot of kids with mood disabilities, is that we're now learn some very maladaptive skills and coping ways that we're breaking the rules. And adaptive skills are very important. Again, looking at these things and measuring these things in schools is very important. Independence. We're going to grow up and have to take care of our own self someday. And it starts in school. I have a responsibility to do that, to help a child learn to solve problems on their own. Learn to help families, help kids with hygiene and self-care and showering every day. If your mood's up and down and fluctuating, showering may be the last thing you think about in the mornings, right? But what's going to make it worse for you is when you get to school, not only is your behaviors a little different, but now you smell. And so you know, these are the important things. Social communication. This is the, yes?
I just wanted to ask a question about the diagnosis of these children. I was thinking and wondering, who usually diagnoses them? Is it their primary care physician?
Yeah.
And if so, how often are the diagnoses correct?
Right. So the question is, who usually diagnoses kids with mood differences or mood issues, and how often are they correct? Well, I can't answer the latter question to any accurate degree. I haven't researched on the accuracy of the diagnosis, but it is in question a lot of times because it's, again, something that's not scientific. Can't put a needle into a kid and say, you know, the probability is so high, we think it's this, and you're not there. We have to
Or
go
the-
off of a behavioral,
I'm
Yeah.
sorry.
Yeah.
Or if you end up in a hospital, then sometimes
Yeah.
that can happen.
That's right, you can get that.
Or that they have mental health
Yep.
people there.
Yeah, the school, in the schools, we have about 13 criteria that a child can receive special education for. And this diagnosis can fall under one of those criteria. But usually before actually the criteria of one of these is emotional disturbance is what it's called, ED. The other aspect I've seen kids come in under is something called other health impaired, where they have bipolar, but because it's some sort of a medical base that we're gonna label this kid with other health impaired and educationally treat. In special ed, as far as treatment goes in schools, the diagnosis does not dictate what services the kids get in the schools, believe it or not. A kid can have a diagnosis of a language impairment and need a residential placement. And if you know the law really well, you know, so it's all about what the child needs. But it's usually those two diagnoses. The first person that's going to diagnose this in most cases, because we do not in schools diagnose bipolar. School psychologists, educational psychologists do not diagnose. That's a clinical disorder, and it's diagnosed by a clinician, which is either an MFT, LCSW, a professional psychologist, a psychiatrist, a pediatrician, and so forth. But those are individuals that have a lot of training in looking at children with mood differences and making accurate diagnosis.
One more question. Do you see many children in your region that are, you know, exhibiting the symptoms but aren't being treated, and their parents won't allow maybe psychiatric intervention?
So the question is, have I experienced or observed children that have exhibited these kinds of differences but don't have a diagnosis maybe? And I think the answer is absolutely, absolutely. So if you talk to people that are, I think, gurus, which I never have, I just read about them and I see them on these lectures, you know, they're mad because kids are getting the diagnosis and they're mad because the kids aren't getting the diagnosis. In other words, we're over-diagnosing some and we're not getting others. And it's because it's such a hard thing to nail down at times, and it takes a lot of follow-through. You don't walk in and read a book, and because you can't read, you know, I can say, well, wow, you have dyslexia. I can sit and look at a kid in about half an hour and watch an error pattern of reading and say, you have dyslexia, assuming you've been to school and you've had the right things like that. But you can't do that with a mood disorder, especially in pediatrics, when this, you know, a few years ago wasn't even thought to occur in children. You can't have this. You can't have this. You're not 18 or 17. Early onset as a teenager. So if you're 5 years old and you're cycling, it must be because you're a bad parent, or because you have some adjustment issue or difference. And I think, you know, that's another reason why.
And the medication also, most parents don't like their children on any medications.
Yeah.
So if certain, well, this isn't so much in children, but as they get older, sometimes they do need the medication to function normally within, you know, so people don't always look at them and can say right away, hey,
Right.
that person's bipolar, she can't talk right, she can't do
Right.
anything.
Yeah, and I think if you look back historically, you go to the doctor tells you what the recommendation is, and you follow it. But what do we have today that you get on and you look at and you say, you know, parent groups, different folks, don't give your kid the med. My kid had this side effect. So there's a lot of influence in that perspective as well. We have a lot of people able to share stories, and I think that I always trust in, you know, in science and doctors for the most part to help my child. The people who you say you're an expert, let's work with you rather than read something first and then say, you know, I'm not going to get my kid vaccinated or do this because I read about this one kid or this group of kids. And so there's a lot of influence in that, and you know, it's a tough call.
Did you say it doesn't make a difference what the criteria is, OHI or ED? Even if they're switched to residential, they don't have to, because I was told they had to switch the ED if they're being put in residential. Is that
Yeah.
not correct?
Yeah, I think that at the end of the day, I'm not certain about that. I mean, if somebody's told you that, it has to be that. I just know that what I understand about the law is that the criteria for diagnosing in special ed does not dictate what the services are. It goes off of something called the present levels in an IEP is really where we get how we're, the services and the goals that we're going to give a kid comes from that present levels. But I think there may be some circumstances where to access certain funding type programs, you have to have this category on the IEP.
It was definitely an OHI, same diagnosis. Just when the determination was made to go residential, I was told that the criteria needed to be switched to ED, which really wasn't, an end all.
Right.
Didn't make a difference, but
Yeah.
I was curious if what you said. I was wondering if it was factual or not.
Yeah, and it may be, but most of the time it's the present levels.
Okay.
Yep.
Good.
Have any of the researchers ever found out what causes these mental illness like bipolar? Is it genetic? You think that anybody ever
Yeah.
researched that?
So what causes bipolar? I don't spend a lot of time
Because of
subscribing,
where it came from.
or where it came from.
Is it genetic?
Yeah.
Where-
Well, I know that there's a high, there's a high hereditary influence there in mood disorders, particularly depression. In fact, I think depression and mood disorders have one of the highest genetic basis among psychiatric disorders.
And they're not
Autism
top-
has a real high one as well. So there is a genetic component, and there's probably an environmental influence as well. But when I do intakes and background, I'm always asking about parents and siblings and all that. Those are factors that can contribute to these things. At the end of the day, it's either environmental things or it's genetic things that cause those, and sometimes it's a combination of those two influences in the presentation that you get with a child. So I'll focus on these coping skills, academic skills, organization. This becomes key when we get into being teenagers and we have 6 classes, and we want a kid to be college bound and kids bright, and now we're managing a whole another tier of demand. Younger kids can be managed by who? The parents, their teacher. Here's, put it in your backpack, take it home, bring it back. And when you get to middle school, that changes. These adaptive skills are very important. They come into play. Sometimes you see kids go through fine. 6th grade comes up, and now it's like, hey, what's going on? This kid had a disability. Why didn't we see it early on? Aren't we supposed to see it early on? It can't just appear all of a sudden. But it's because the demand in school changes. Yikes. And we have spatial skills here that we'll talk a little bit about in a moment. But social awareness, spatial processing, what is that? That's the ability to look around this room right now. I'm shifting and taking in a lot of visual input. I want to make sure that when over half of you start falling asleep, then I know it's time for me to quit. But right now I'm doing okay still. But that ability for me to look around and take all that information in and use it is an important skill. It's a very important social skill. And you see kids with mood disorders have a very difficult time doing that sometimes. Don't take all that in and process all that together. And we have visualization difficulties that can influence negative outcomes. So difficulties seeing, what's going to happen next period? Walk me through it. Well, I don't know. Well, let's just look at it in your mind. Let's see it. And then, this diagram here about educational treatment, we're done it right now, right? At 7? Okay, so I'm going to go along through here and kind of speed it up here a little bit. But you see that this whole thing is connected, and every research study that I've ever seen says best outcomes are when you have all the players doing what they're supposed to. That's the ideal world. When a parent can be a full-time parent to one kid that has a difference, and a school can focus full-time on one kid, that's ideal. But any good design will say, oh yeah, you need this, you need all this, and then you have the best outcome. Surprise, okay? My job sometimes is to find what we don't have in this circle, is to really understand, well, this kid's not on any meds, and I think referral to a psychiatrist, I need to get this kid seen by somebody with that lens, and look at this, and the same thing. This is my job in here. This is my job here. This is my job. You know, sometimes it's getting this parent access to support so we can talk about sibling types of dynamics and counseling with families and so forth, okay? Why is education so hard for kids with bipolar disorder? Look at all the different, little learning will take place if mood is unstable. Very little learning will take place, we know that. But here we have these, 4 different kinds of positions a kid can come to school in, 4 different kinds of states. This is very dynamic for kids. I think this is probably one of the hardest children to educate in public schools, in my experience. I've never read this, but it's just my experience that very dynamic. And the outcomes are not always favorable, very hard. And that's, it's not every kid gets to residential, in different ways. That's sometimes where they need to be, where there's a lot of structure and knowledge. But not every kid gets to that place. We have to look at behavioral interventions now. And I'll just have a little discussion here about these kinds of behavior interventions that can make plans for kids. My job is to assume this. If your kid's at a high school and has 6 teachers, those teachers will not be experts in bipolar disorder. I have to assume that. And nor do I want them to be experts in bipolar disorder. I want them to be an expert in how to educate a kid that we all create a plan for. I want them to use and understand the accommodations that the specialists have proposed that we put into place. And I want that teacher to make sure that he or she knows that we have support for you. Who will you contact if you see this? I want that teacher to have education about that specific kid in general. We've learned these are the triggers here, but we all want teachers to be experts in our kids. I have 3 children myself. I want my teachers to know my son and daughters, but I know it's hard, realistic. So then we have 2 plans. Ideally, we want a plan that says this is what to look for when we're having a hypomanic phase, and this is what to look for when we're depressed, and this is how we respond. It's 2 different days. It should be 2 different days almost that we're treating the kid in schools. If we're just focused on this behavior plan every day, we're going to be having problems when the kid comes to school depressed. If we can get the kid to come to school, that is. Goals should be attendance, participation, and then production. But what do we want in schools? We want this. Nothing else really matters. We want you to produce. Get there and write that down. Take notes here. Get there and write that down. Work here. Do this, do this, do this. And that's sometimes, we don't have this. So I sometimes have to slow it down and say, wait, don't let him do anything. He doesn't have to write anything down. And, that makes some people go, what? Teachers go, what? Not what everybody else is writing stuff down. That's okay. He's not going to. If you get him to raise his hand and look at you during the class, that's a good goal to shoot for and get through the class. So it's sometimes going backwards a little bit so that we can go forward. And we have to also consider sleep disturbance. It's a huge, probably put 5 slides on here just about sleep patterns and the effects on education and learning with different sleep patterns. Interventions include at school, group counseling. If I've got 2 or 3 kids with mood differences at school, I want to get permission from their parents so we can do a group counseling activity so we can say, you're not alone. We can do this together. There's other people out there like you going through the same issue. In individual counseling, focuses on triggers. Got to know what triggers are. When is your mood up? If I can get a kid to start predicting, I'm cycling again. That's such a big accomplishment as a school psychologist in the schools. If I can get a kid to start being aware of that. And that's when we're making progress. Maybe now we don't know what to do now, but at least I know my body's changing right now. And this comes along with cognitive behavioral therapy, okay? Occupational therapies to help in those sensory differences and with output and mood. We have a lot of behavioral mood charts where we're looking at behavior and mood, trying to help kids track their behavior and mood, okay? Academic considerations, I'll keep moving forward here, but there's a lot of really good stuff here if you take a look at this. There's a lot of books out there that talk about recommendations for kids. If you have a child with a mood difference, you should be buying some of these books and then bringing that book to the meeting. I love it when I see a parent come to an IEP meeting and have a book or two with some tabs, and think, good, somebody's done their homework. This parent's done the research. We're going to have you as an active participant in developing this IEP. And that's how you, as a parent, have to operate if your kid has a mood difference. Ecological considerations, staff training on triggers and mood and accommodations. At the beginning of the year, sometimes I'll meet with as many teachers in one day and maybe carry over the next day. This is such and such. This is what we have to watch out for. So as a parent, you asking the school to consider doing that. If you think of it being a teacher, you have a stack of papers that describe kids' differences versus somebody coming in and saying, this is my student, or this is Billy, this is what's going to trigger him. What are you going to remember more as a teacher? So that's what our responsibility is. Okay, medical considerations, likely to be on medication, or often 2 to 3 medications, a whole bunch of issues surrounding that. They have side effects. They will affect stamina, focus, and mood in school.
Yeah, and it could take a long time before they get the right ones together. And I know they're working on the DNA part where they can, because I almost died from one of the medications they gave me. And I ended up on the railroad track eating bushes and a 12-day plasma transfusion.
Wow.
But anyway, that they're working on using your DNA and being able to know what medications are going to hurt you.
Wow, that's interesting. Yeah, that you're predisposed for with your DNA to certain med. That's great. And then we have some accommodations for medication. I'm not going to go over this in light of the time that I have here, but there's some interesting information there about accommodations with medications. So if you're a parent, you have a child with a mood disability, you've got to understand what accommodations, from being able to leave the classroom and get a drink of water to make sure that you're hydrated enough is an important thing, it's key. Okay? And then comments on special ed, got to know your rights. My job in the schools is to help you know your rights, believe it or not, as a psychologist, as an educator in the special ed system. But I don't always take the time to tell a parent. I can't tell a parent every right they have. I want to give them access to places they can find it and then be available for questions. Importance of knowing all your options. You've got a lot of options. There's a lot of options. Most parents don't know that. And our job in the schools is to make sure that I'm educating your son or daughter appropriately. The word appropriate is an important consideration in the law of special ed. In my own home, I want the best for my kids. I want the best for my kids, and that's my job. But I know that in the public school system, the word appropriate comes into play in the legal system. The importance of an IEP, placement considerations, and then look at, this was sort of quick, I just thought, what about the terminology, that you're going to be faced with the moment you walk into special ed, all these words now, it's like you got to go pull your flashcards out and memorize what all these things mean. Because the way we talk sometimes, wait a minute, they don't understand what I'm saying. And that's it. I appreciate you guys spending some time